Welcome to the Radiology Advances Podcast. Today, we're doing a deep dive into something pretty intriguing, the idea of spotting a pulmonary embolism, a PE, through CT without needing intravenous contrast. Think about those patients where contrast is a definite no-go. You know, the ones with really poor kidney function, or maybe they've had a serious reaction before. So what if you could still get meaningful information about PE in those tricky situations? That's what the paper we're looking at today explores.
It's titled Pulmonary Embolism Detection Without Intravenous Contrast Using Electron Density and Z Effective Maps from Dual Energy CT.
Right. Published in Radiology Advances. The study is by Tommaso De Angelo, Simone Barbera, and senior author Dr. Giorgio Assenti, along with their colleagues from the University Hospital in Messina, Italy.
It's not a trivial issue. Severe CKD, AKI, a documented anaphylactoid reaction, these are all real contraindications we have to deal with.
They're not rare occurrences either.
No. If you go back to some of the foundational studies which really helped validate CTPA, you see a considerable number of patients were actually excluded because of contrast issues, hundreds for allergy reasons, over 1,000 because their creatinine was too high.
Which brings us back to the study. How can dual energy CT possibly help without the contrast?
That's the clever part. They're leveraging the inherent capabilities of dual energy CT. Specifically, the scanner type they used was a dual-layer dual energy CT, which has detector layers that simultaneously register low-energy and high-energy photons from a single X-ray source. From this simultaneously acquired raw data, you can do more than just create standard-looking images.
And the algorithms they focused on were these electron density and Z effective maps, ED and ZF.
Exactly. Let's unpack those a bit. The electron density map basically tells you about the concentration of electrons in a voxel. It's closely related to the physical density, sort of how much stuff is packed in there.
Okay, what about ZF?
Z effective estimates the average atomic number of the material in that voxel, so it gives you an idea what kind of atoms make up the tissue.
So it's digging deeper than just the overall attenuation we see with Hounsfield units on a regular CT. It's more about the composition.
That's the key distinction. Dual energy CT, because it gets data at two energy levels, lets you tease apart materials based on properties like electron density and atomic number. You get more specific info about what something is made of.
And the underlying idea, the hypothesis, is that a blood clot, an embolus, looks different from flowing blood on these maps.
The thought is that these specific dual energy CT-derived maps, ED and ZF combined, might amplify that compositional difference enough to make the clot detectable. And the authors do point to some earlier work, phantom studies and case reports, suggesting ED maps could potentially distinguish thrombus from blood without contrast.
Okay, that makes sense. So how did they set up this study to test that hypothesis?
It was retrospective design. They went back through their records for patients who had a chest CT on their dual-layer dual-energy CT scanner over about 2 years. These were scans done for suspected PE or acute aortic syndrome, and patients had to have had both an unenhanced phase and a contrast-enhanced phase performed.
Right. So they've got the patients, they've got the unenhanced raw data. How do they actually read those ED-ZF maps to look for PE?
Okay, so they generated these color-coded ED-ZF maps from the unenhanced scans. Then 2 radiologists, one more experienced, one less so, independently looked at only these unenhanced maps in a blinded fashion. They didn't know what the contrast scan showed, and crucially, they'd been trained beforehand.
Trained how? What were they looking for?
They were shown examples. The training focused on identifying spots within the pulmonary artery lumens on these unenhanced ED, ZF maps that look different, a different color or intensity profile compared to the surrounding presumed blood pool. Importantly, these different-looking areas had to spatially match up with where known clots were seen on contrast-enhanced scans from other training cases. They were hunting for that signature of a clot based on its composition.
Okay, so a trained, blinded read of the unenhanced maps. Then what? How do they establish the final ground truth?
After that initial read, and after a washout period to help prevent remembering the cases, the same 2 readers did a second blinded review, this time looking at the contrast-enhanced CT scans using those 40 kV virtual monoenergetic images. This consensus read, where they both agreed on the contrast-enhanced CT, served as their final definitive reference standard for whether PE was present or absent and where it was located.
So they ended up with 150 patients in their final group.
Yes, and within that group, they found PE confirmed on the reference standard contrast-enhanced CT in 20 patients.
20 out of 150, so about a 13% prevalence of PE in this particular cohort. Okay, the moment of truth. How well did looking at just the unenhanced EDZF maps do at finding those 20 people?
This is the core result. The overall accuracy correctly classifying patients as having PE or not was 86.67%.
Okay, pretty high. What about sensitivity and specificity?
The sensitivity for detecting PE was 85%, meaning the unenhanced maps picked up 17 out of the 20 true PEs, and the specificity was 86.92%. So out of the 130 patients who didn't have PE on the CECT, the unenhanced maps correctly identify 113 as being negative.
Okay, 85% sensitivity, roughly 87% specificity. Those numbers sound encouraging, but clinically, we often think in terms of predictive values, right? Especially negative predictive value for ruling out something serious like PE.
Absolutely crucial point. And this is where the findings get particularly interesting for potential application. The negative predictive value was really high in this setting, 97.41%.
Wow, over 97% negative predictive value? So if the unenhanced EDZF map read was negative,
It meant you could be very confident based on the study's data that the patient did not have a PE. It suggests this might be a good rule-out test.
what about the positive predictive value if the unenhanced map looked positive?
That was lower. The PPV came out at 50%, so if the unenhanced map was interpreted as positive, there was essentially a 50-50 chance that it represented a true PE confirmed on the contrast-enhanced CT.
So a positive finding on the unenhanced map isn't definitive by itself.
Exactly. It raises suspicion strongly, perhaps, but based on these results, you couldn't hang your hat on it alone. In the study, the confirmation was the contrast-enhanced CT. In a real patient who can't get contrast, a positive unenhanced map leaves you needing another diagnostic avenue, maybe leaning more heavily on clinical probability and D-dimer, or considering VQ or MRI scans if feasible and appropriate.
What about consistency? Could different radiologists reliably see the same thing on these maps?
Good question. They looked at that too. They measured agreement both within the same reader looking at scans again later, intra-observer, and between the two different readers, inter-observer. The agreement was excellent. Cohen's kappa scores were 0.90 or higher, both for intra and inter-observer reliability.
That's encouraging for potentially implementing it more widely if the performance holds up. You mentioned this was on a dual-layer scanner. What about other types of dual-energy CT scanners?
They do touch on that. They suggest similar ED and ZF reconstructions might be possible on other platforms. Dual-source rapid KV switching scanners, maybe even photon-counting CT in the future, but they rightly caution that this needs specific investigation.
What do the authors themselves point out as weaknesses of this study?
They were upfront about several things. One, as we discussed, the reference standard wasn't a dedicated optimized ECG-gated CTPA protocol for every single patient. It was a mixed cohort scan for different reasons. The sample size of 150 patients with only 20 having PE is relatively small for this kind of diagnostic accuracy study, and it was done at a single institution. Both factors that could limit how well results apply everywhere else.
And that low number of PE cases, the low prevalence, that can skew the predictive values, right?
Exactly. A low prevalence tends to inflate the negative predictive value and decrease the positive predictive value compared to what you might see in a population with a higher baseline risk of PE. They also didn't correlate results with D-dimer values, which could potentially increase the diagnostic accuracy of this technique.
So future directions would include that integration plus testing on other scanners?
And definitely larger multi-center studies. Ideally, you'd want a study focusing specifically on patients with known contraindications to CT contrast, enrolling them prospectively and evaluating this technique across different levels of clinical suspicion. That would give us the clearest picture of its real-world utility, where it's actually needed most.
Well, that's our deep dive for today on this fascinating research. We hope this look at unenhanced dual energy CT for PE detection has sparked some thought about the evolving possibilities in radiology, especially for tackling challenging clinical scenarios.